Hello, my name is Carrie Simo, and I am the hepatobiliary surgeon for the ProMedica Health System in Toledo, Ohio. Today, I will be speaking regarding the utilization of laparoscopic liver surgery to improve access to care in hepatocellular carcinoma in the non-university world, a recent fellowship graduate experience. So, we all know that patients with hepatocellular carcinoma are frequently undertreated, and this is even more glaringly obvious in the non-university setting. Less than a third of eligible and appropriate patients for resection or ablation of their HCC actually receive it. Patients are frequently downgraded to less effective treatments, such as local regional treatment with TACE. We sought to evaluate the effect of adding a fellowship-trained HPV surgeon with laparoscopic liver surgery experience on the access to care for patients with HCC in a non-university setting. We reviewed all patients treated for hepatocellular carcinoma from January of 2010 to December of 2015, utilizing ProMedica's Cancer Institute registry. I started within the system in September of 2013 after completion of my HPVA fellowship. We analyzed both outside and within the health system all patients with the diagnosis of HCC to determine the number of treated patients, as well as specifically to look at patients that underwent surgery for their diagnosis. An additional sub-analysis was performed regarding patients that were operated on within the system by the hepatobiliary service. So we found overall there were 94 patients with a diagnosis of hepatocellular carcinoma within the registry. These broke down into two even groups of patients, with 47 patients within the 45 months before I came and 47 patients in the 26 months after I came, to make up the total 6-year time period that was evaluated. Over this time period, there was an increase of 25% in the patients that were seen with this diagnosis, and there were more than double the number of surgical interventions for HCC between the two time periods. Surgery performed within the system increased more than 4 times previous in the last 26 months. If you look here, you can see that within the first 45 months, the blue denoting Toledo Hospital, the mothership for the system, and red, the other, which is the institutions or hospitals where typically these referrals were done, especially before I came to be part of the system, that there were a total of 12 operations done, with 6 being within the system, all open, 5 resections and 1 ablation, and then 6 were sent out, including 1 transplant. If you look at once I joined in 2013, there's overall number of patients that are being treated for HCC, and additionally, most of them within the health system. Of note, the ones that were sent out were a patient who subsequently underwent a transplant, and another one that was a pediatric patient. So what types of surgeries were done for HCC at Toledo Hospital within the health system? If you look here again, within the first 45 months, these were all open operations with 4 resections and 1 ablation. And really in 2013, not only were there an increase in the number of operations due to just the presence of an HPV surgeon, but really the additive effect of laparoscopic liver resection and ablation helped greatly increase these numbers. Overall, the characteristics of these patients that were operated on by the HPV surgeon included average age of in their early 60s, a BMI that was around 28, and hepatitis C was their number 1 diagnosis for the reason for their end-stage liver disease, followed by NASH and NAFLD. Of note, 2 patients actually had no cirrhosis, and the patient's MELD score on average was around 12. 6 of these tumors were found as a result of surveillance, with the others being either symptomatic on presentation or incidental findings on scans for other reasons. The short-term outcome in the patients operated on by the newly graduated HPV surgeon included liver resections. A total of 11 were performed, with 70% being done laparoscopically. 3 did not go to the ICU. Overall length of stay for the patients was about 5 days. And regarding complications, there was one Clavian 5 complication in a patient that had a right hepatectomy in conjunction with CT surgery for a vena cava and atrial thrombectomy. The patient had a variceal bleed on postoperative day number 3. A second patient had a Clavian 4 complication with a bleed that required blood transfusion but did not require return to the operating room. Further, regarding liver ablation, 16 patients underwent this procedure and they were all performed laparoscopically. 14 did not go to the ICU, and their overall length of stay for the majority was 1 to 2 days. The 2 that went to the ICU included one that had an issue with the psychiatric medications and a second one who had a SIRS or ARDS response to the treatment and required mechanical ventilation. Follow-up short-term showed a 30-day readmission rate overall of 18.5%, with liver resections having no readmissions and the ablations about 30%. This reflects likely the patient selection, with healthier patients being chosen for liver resection and the patients with ablation having more underlying comorbidities or problems with their end-stage liver disease. The readmissions in this group were, for the most part, related to those reasons and not direct surgical complications. Intermediate survival, we looked at median follow-up of 1 year, and 21 to 27 patients were alive at that time. Of course, we've gotten busier and continued to grow since then, and we're looking forward to having a new partner join so that we can get some concrete, good 5-year data out. So in conclusion, the presence of a fellowship-trained HPV surgeon with laparoscopic liver surgery experience greatly improves access to care for these patients in the non-university world. The ability to offer this modality to this patient population with acceptable morbidity or mortality is absolutely achievable by the recent fellowship graduate. Thank you.